And then Dr. Trevino, can you give me a thumbs up? Can you see my laser pointer on the screen? Okay, good. We'll use that later on. All right, so my name is Saoul Mancha. Like mentioned, I'm one of the primary care residents at the school. I have no conflicts of interest or financial disclosures to report. So just a couple of trivia questions. Anybody can type them in. If Dr. Trevino, you can shout out the answer. But does anybody know what year the first mentioned VEP was? It's a little bit harder to do this on a live webinar than inside of an actual lecture hall. But so the first mention was 1934. And so I always do this to kind of highlight the fact that this is not new technology, right? This has been around for quite a while, about 86 years or so, right? Just to recap, the first couple of slides is going to be to kind of talk about what the VEP is, what the ERG is. So the VEP is going to be testing that we can do to actually measure the function and the integrity of the visual system, right? Coming from the retina all the way back to occipital lobe. Now, historically, these have been kind of used to check and monitor and study the function of the afferent visual pathway, right? So there are multiple different types of VEPs. We have flash VEPs, we have pattern ERG VEPs, multifocal. But in general, that we're not going to get into too much depth throughout the testing for today. Just knowing that for the VEP, this is going to be like a representation of a normal wave pattern that we're going to see, with the N91 being the first negative waveform. That's going to represent where the signal has kind of caused a response in the visual cortex, and then the P100 is going to be the dorsal extrastriate cortex. The next one, the electroretinogram. If anybody wants to shout out when they think the first electroretinogram was performed on a human, what year would y'all guess? And again, this is a lot easier on a lecture hall because people can just kind of shout out the answer. But this answer is 1877. So this is even further back, right? So this is more than 100 years old type technology that we knew we could kind of record and kind of track. Granted, nowadays it's a lot more sophisticated than what it was prior. So ERGs, the electroretinograms, just like the nomenclature kind of tells you, it's going to give you a function. It's going to give you what's going on inside the retina itself whenever we kind of flash stimulus of a known luminance, right? And so typically whenever we have an A wave, not the next picture will show this a little bit better. The A wave is going to be the photoreceptor response. Down here, that's the first negative response. The oscillatory potentials here are going to kind of give you a representation of how well that American system is kind of doing and how it's functioning. And then the B wave is going to be a little bit more the inner retina, where it's the bipolar cells and the glial cells, right? So just like the VEPs, we have multiple different types of ERGs, right? We have a full field, we have multifocal, and then the next slide we'll see that the pattern ERG. Now, the full field is going to be a flash stimulus across the whole retina, and we're getting a global retinal response, right? So the one downside to this type of testing is that we're going to mask small retinal lesions, right? You can kind of be overlooked or kind of hidden within that response that we're picking up. And that's where this multifocal comes into play. Because now with this multifocal, we can actually check multiple different points within a little small area, right? Typically, we're going to check the macular tissue and the macular functional integrity. So with multiple local macular responses, we're able to kind of capture and reveal localized macular dysfunction. And then next with the pattern ERG, these are pretty interesting because they're kind of finding out in some of the research studies that we can kind of get a good idea of the ganglion cell function within these waveform patterns. And really they're looking here at this N95 wave. And so we're gonna keep that in mind for the future part of the slides. So the first study I want to talk about and kind of mention, and I know I don't have a whole bunch of time, but I did want to kind of just throw in some studies that are going to highlight the importance and why we know that they would work in everyday type practice. And the first one I wanted to cover, something we see every day is diabetes. The next topic would be macular degeneration, and the next one would be glaucoma, something we run to day in day, right? So in this first study, let me move my presenter view real quick so I can see my slides. So in the first study, what they were trying to do is they were trying to use VEP, and they were trying to find early visual dysfunction in type 2 diabetics. And this is important in the earlier stages with VEPs. And these are going to be in patients, diabetic patients who had not yet clinically shown manifestations of diabetic retinopathy. So mind you, MAs or microaneurysms, stop-blotting hemorrhages, exudates, and so forth. And so they had 100 subjects sign up. 50 of those were diabetics, and 50 of those were controls. And what they were looking at, they were trying to look at the latency for the VEP response and also the amplitude, see what the response is, if there's any kind of deficit when you're comparing the diabetics to the normal controls. So here again, we're just going to see their inclusion criteria was type 2 diabetics that were proven to have plasma glucose levels above the 126 milligrams per deciliter. One thing I didn't really like about the study is that they didn't really mention what that normal visual acuity was, right? They didn't say is that 20/20, 20/5, what it was. They just said these patients had normal visual acuity and they had a normal fundus exam without diabetic retinopathy, right? Without any kind of complications. So again, they're trying to find these early functional manifestations of deficit between normal and abnormal retinal responses. So the exclusion criteria, of course, is going to be, something that's going to interfere with that signal: cataract, glaucoma, vitreous opacities, optic atrophy, diabetic retinopathy, long-standing hypertension, any kind of cerebrovascular accidents, chronic alcoholism, peripheral nervous system disorders, and other endocrine disorders. All right, because those are all going to play a factor in that pathway. So what did the researchers find? So if we look at this graph, we can examine the findings. These dark bars are going to represent the diabetics, while the white bars are going to represent the controls. The study found that when comparing the latencies between both groups, that the diabetics had an increase in latency in their response, all right, compared to their age-matched controls. And then also with the amplitude itself, the amplitude for the diabetics showed that there was a decrease in the signal getting back, and then that the controls, a little bit higher. So what is this telling us? That even though these patients had not yet manifested the clinical signs of diabetic retinopathy, there does seem to be some type of functional problem going on, right? Some early manifest diabetic retinopathy that we're not actually clinically seeing with the slit lamp examination. They didn't use any OCTA in this study, which would have been a nice extra test to have. But again, we're not picking anything up early on, but there is going to be some kind of functional problems happening. Okay. And so that was the VEP for diabetics. This next one is going to be the use of electroretinograms. And in this study was not trying to prove that you can find diabetic retinopathy dysfunction or retinal dysfunction from diabetes. However, what this one is trying to do is they're trying to show that between two different testing for electroretinograms, the fixed luminance and the multiluminance flicker electroretinograms, which one shows the better reproducibility between test takings. And so what they had patients with non-proliferative diabetic retinopathy. There was 87% that were mild, and then the remainder were moderate. They also underwent ultrafield fluorescein angiography to get a good idea of what the retinal ischemic index was for this test. And they're going to compare those two later on. And then again, they checked the fixed and multiluminance flicker ERG. And they repeated these 4 times within a week apart, or a little bit greater than a week apart. So the study had 40 eyes. These are from 20 patients that underwent a comprehensive eye exam and were proven to have mild or moderate proliferative diabetic retinopathy without clinical significant macular edema. And the vision was reported to be around 20/50 or better for all the participants. The patients were also examined again with the fluorescein angiography, so they can get that ischemic retinal index or retinal ischemic index. The study excluded any participants with dense cataract. These are all these yellows, these darker orange colors, all the exclusion criteria. So dense cataract, active macular edema, history of optic neuropathy, vasculopathy, glaucoma, panretinal photocoagulation, focal macular laser, with less than 2 months, or anti-VEGF within 4 months, and ocular surgery within 6 months. They also excluded any kind of patients who might have tremors, blepharospasms, or dry eye, because just a quick reminder, for the electroretinograms, they do use the lower lid electrode. And so those are going to interfere with that signal that we're getting in the end, right? So the researchers used the multiluminance and the fixed luminance electroretinograms in the study. The fixed luminance electroretinogram is going to be a full field flash stimulus of a known and constant luminance throughout the testing procedure, while the multiluminance, as you might have guessed, is going to be one that the luminance value changes, and those are going to steadily increase as the duration of the test occurs. So there were 4 parameters that the study was looking at, and so one was the magnitude for both the fixed luminance and the multiluminance. that there was the amplitude for the multiluminance and the fixed luminance electroretinograms. What they concluded was that at the end of the study, they found that the fixed luminance phase value had the highest reproducibility between the test sessions. Again, these were tested every week or so over a 4 to 8 week testing period, right? And then again, they use forcing angiography because they wanted to compare that function to the structural changes that we can see, right? And so what they found is that there's a negative correlation between that retinal ischemic index and then also the flicker phase, meaning that the more ischemia is going on, the worse that the flicker is going to be, all right? So in this study, what the researchers are supporting are the ideas that these in-office non-invasive electrodiagnostic testings can be used to kind of track these diabetic retinal dysfunction over time, and or use this as adjunctive procedures with anti-VEGF agents. Back in 2017, 2018, the FDA had brought in the use of Lucentis for diabetic retinopathy. And when they brought in that usage, what they did is now they said you can use Lucentis for any staging of diabetic retinopathy without having to have macular edema involved. And so what this kind of is helping us out with is, if you're kind of working with a ophthalmologist that's doing these surgeries, you can actually use these in office and kind of get the patient a good idea, and then give yourself a good idea of how bad they're progressing over time, right? So this is not necessarily saying you're going to use this right away for these mild non-proliferative, where you can just kind of initiate like a diet change with a primary care doctor. This is just showing you and the patient, okay, let's watch you over time and figure out what that functional deficit you might be undergoing that you're not picking up or we're not seeing. Okay. This is just going to be an example. I didn't want to just talk purely about the cases that I had seen or the research that I'd looked at. I did want to show you a couple of examples. So in this first one is going to be the fixed luminance flicker ERG print-off, and this is going to represent what we're going to see on a normal response, right? On this top part, we're going to get the magnitude of the responses for both the right eye and the left eye. We see a nice sinusoidal waveform pattern, and this is typically what we're going to get in a healthy individual. There's no deficit to this amplitude where it's decreased between either eye. This magnitude and phase plot, these are a little bit more trickier when you're first kind of reading them or learning about them. So I'm just going to highlight them real quick. So each one of these little blue dashed lines is going to be an individual part of that testing sequence that's kind of mapping for you. And so what we typically see on individuals, whenever you're kind of stimulating the retina response is able to keep up and maintain that response time and time and time again in a healthy individual. And so what we get is a nice tight cluster within this magnitude and phase plot. If there's any kind of dysfunction, you'll see a widening of this response, because every time you're stimulating that retina, it's not able to keep up with the same response, and it's not able to give you the same quality of work. Also, what you want to look out for is the phase, which is these degrees. The phase is just one of the timing sequences that the algorithm for this testing sequence uses to get you a good idea of where it should be. So in typical for a normal individual, it's going to be above this 270 range. And then bear with me with my very limited computer skills. I'm going to try to overlay another image. So this one's going to represent something that you would find on a unhealthy retina that's showing some kind of dysfunction. In this case, we'll just say it's diabetic retinopathy. And so the first thing that caught my eye was, now we lost this beautiful sinusoidal waveform, and now you see there's just weird disruptance of that wave pattern, right? There's a decrease in amplitude, and then the wave structure itself is no longer normal in both the right and the left eye. The right eye looks a little bit worse. And then here in this bottom, on the magnitude and phase plot, we can see what we're mentioning earlier with the cluster of responses. Now, as wide as this response is, it's showing you that every time you're kind of flashing the stimulus and you're getting that retinal response, you're not getting the same retinal response every single time in the same sequence. On this one, you're actually kind of out of phase. And then the average response is this longer line right here. It's showing you it's closer to that 180 than that 270. So this right eye definitely, again, is showing us that there's some kind of there's some kind of functional loss in this retinal tissue to keep up with these signals. The next next study that I kind of looked at, this is something we run into every day, macular degeneration. We know with the multifocal ERG, we can use these for like the plaque window type patients, but this study was pretty interesting, and it's one of my favorite ones. This one came out of Hong Kong. The researchers were using, I'm sorry these didn't highlight, I thought I had these highlighted for you all, but I'll just kind of point out what I'm going to talk about. So again, these researchers were using the multifocal electroretinograms to find variations in the retinal responses in patients with pre-AMD and early AMD. I'm not really a huge fan of that term pre-AMD. I'm kind of on that, like, is it AMD or is it not? And so, but I do approve of them using that term pre-AMD in the study, because what they did, they were trying to look for patients who exhibited unilateral AMD in one eye, and the contralateral eye had no clinical manifestations of AMD. And so that's why they use that term pre-AMD. So they actually started off with 1,500 participants, and they dwindled them down until they finally found these patients they wanted, the 15 with no AMD in one eye, and the other eye had very early AMD. And then they compared those to 20 age-matched norms, and they're trying to figure out, is there any kind of early, prior to any kind of structural change, can we pick up a functional change inside these eyes, all right? And again, the multifocal ERG is very good about picking up these small local deficits, right? So again, you know, in the patients we see here, there's 1,500 local resident individuals in that Hong Kong area that they kind of ran through, and they got their individuals they wanted. So all the participants showed no AMD in one eye, and the other eye was, you know, early AMD with a visual acuity of 0.7 or better. And then they compared those to the control groups. What the study found, and I'm going to show you an example of a print off here in a minute. This is a lot of numbers here. So what we're going to be looking at here is the normal patients, the early AMD, and then the pre-AMD findings here. So what they found was that in this first ring, which is that central ring on the multifocal electroretinogram print off, that central ring shows that there is an amplitude decrease when you're looking at the patients who already exhibit early AMD, and then also even the patients who have not yet had that clinical manifestation of seeing any kind of AMD changes. And then they're also finding that the normal latency for the R1 ring is quicker than the early AMD and the pre-AMD. And then as you go away from that foveal center, the responses kind of blend in, and they're not really getting a large change that are significant. But this R1 ring does show some changes, and we'll look at that here. So down here, you know, we typically see, you know, what this turtle shell, you know, looking pattern looks like. I actually like to look here. This is going to be a print off of a normal individual, and you see that this center this waveform is going to be the R1 ring, and then as you move out, this is going to be the R2, R3, R4, R5, and so that's how you're going to view this. I actually like to kind of look at these waveforms right here and kind of figure out, is the black line, which is what the patient's response is it matching up to that normative data, which is the red waveform? And so this patient's hitting all the marks in every single ring structure, both in the right eye and the left eye. So here we're going to overlay, again, very limited computer skills, but that's why I went into optometry. We see that this R1 ring, that there is a deficit here. And again, these boxes right here are going to be for the R1, R2, R3, R4, R5. We're seeing that there's a deficit, right? So we're picking up down here this little turtle shell looking appearance. But also, again, I like to look down here, and I see that blackness. Let me try to zoom in for y'all because this is kind of small. Let me see if it's going to let me. Give me 1 second. Okay, sorry about that. I don't know how to make it let me zoom in, and I was not supposed to do that. Okay, so anyhow, if you can kind of squint, you'll see that the patient's black responses for this waveform are significantly hindered from the red responses, and that's just the main point, right? So, you know, again, these type of studies are just kind of proving time and time again the value of these very, very old testings, right? The electrodiagnostic testing that we've had since 1877 and then 1934, that you can start using these in the clinic setting to kind of find these early changes in these patients. And again, I didn't really have a lot of time with this lecture to kind of go through extra type testings. We already know that with plaque O'Neil, we always get a baseline, right? Visual field 10-2, we get the fundus autofluorescence, we get multifocal ERG, and all that good stuff. So with the Plaquenil, what we're going to be looking for, not necessarily looking at that R1 ring. As we know with the hydroxychloroquine, it's going to cause that bullseye type pattern. It's going to be that perifoveal region. And so this one, you're going to be looking at this R2 ring and this R3. And you can highlight, you can get them highlighted up here, right? R2 and R3. And we see that there's some structural functional changes down here that tissue is not responding normal. Okay, this next study, this one's pretty cool. This one actually came out of the Wills Eye Hospital back in 2018, I believe. So it's fairly new. So the researchers were interested in using standard state pattern electroretinogram and then also short duration transient visual evoked potentials in these glaucomatous eyes, and they're comparing to the healthy eyes. So I like this one because they're using two different types of electrodiagnostic testings, right? And so what they were looking at is they were trying to see if they can use these tests to discern between glaucomatous and healthy eyes. And so they had 40 cases of glaucomatous patients and then 41 controls. All participants had a comprehensive eye exam and visual field performed prior to the enrollment of the study. Some of the exclusion criteria for the study included the previous history of incisional eye surgeries or ocular procedures within 1 month prior to the enrollment, or any visual reduction past 6/12, any history of eye trauma or neurologic pathology. So these researchers, and again, this one, well, I guess it highlighted this one for me. So this is a lot of information, right? So what the researchers were using, they were using the pattern ERG and then the standard state or short duration transient visual evoked potentials to kind of figure out if there's any kind of changes between the glaucomatous dysfunction and normal retina. The parameters of interest for these testing were going to be the magnitude D over the magnitude ratio, and the SNR. And so this magnitude D is going to incorporate both the phase consistency of each response, aligning them and overlying them. And it's going to compare that, and it's going to also include the amplitude of the responses. So compared to this magnitude D over magnitude ratio, this is more or less just how well that phase lines up time and time again after each testing. And then signal to noise ratio is more kind of going along the lines with the amplitude. So it makes sense that one of the better parameters to kind of check for this dysfunction is one that uses both the phase consistency and then also the amplitude, which is this magnitude D. And so what the study actually found was that in these glaucomatous patients, their magnitude D value was actually lower than the control value in both the low contrast setting for the pattern ERG and the high contrast setting for the pattern ERG. So we're seeing very similar results. So this could, give us some more ideas in the future as far as using these pattern ERGs to kind of pick up these early changes in these glaucoma suspects, right? The VEP, there was a small change that they were able to kind of show there was an increase in latency for the low contrast response for the VEP, and then increased latency for the controls. But whenever you looked at the high contrast, it was actually the opposite. And so these were not statistically significant enough to actually make any kind of conclusions from this data. But as far as the pattern ERG, the magnitude D did show that it had statistically significant differences between the glaucomatous eyes and the control eyes. So again, what they concluded was that, this magnitude D was the most accurate parameter for discerning this glaucomatous dysfunction versus the normal retinal response in both different groups. Here we go. So I was looking for this one. So this slide right here is going to show you an example of a normal healthy individual with a pattern ERG print off. And so here, this is going to be the high contrast on this top portion and the low contrast on the bottom portion. And so again, we see this nice sinusoidal pattern. This is showing you that the retina response, every time we kind of stimulate that retina and those ganglion cells, that they're able to keep up with the response time and time again. Because this is not just one screenshot. This is all these little testing that are overlaid, and this is what the end result. And so we're showing that this is a nice, healthy individual. When we compare that to this unhealthy individual, we lost that sinusoidal pattern, right? So this kind of just goes hand in hand with if you're having these retinal ganglion cells that necessarily haven't died off yet, but they're sickening, right? They're having trouble keeping up. They may be able to respond one time, but the second time, third time, fourth time, fifth time, every time you keep hitting them, they're losing their ability to kind of give out the same quality of work, right? So in this individual, we can see that the right eye has a little bit more dysfunction in both the high contrast and low contrast when compared to this left eye. And so, again, these are just a few different research articles. There's plenty of them out there that are showing that we should be using these in our clinical setting. Again, it's not brand new technology, right? It's very, very, very old. Oh, here's again a very rudimentary computer skill. This is my wizardry coming up. So this first shock wave is supposed to let you know, okay, this is going to represent the electroretinogram, right? As we mentioned earlier, electroretinogram, it's telling you exactly where the magic's happening. It's in the retina. So you can use these to kind of help you kind of discern what's going on with any kind of macular lesions or any kind of changes within the fundus. The VEP, on the other hand, is going to give the pathway from that retina all the way back to the occipital lobe. And so again, that's just the VEP, and these are the typical print-offs as we see in the bottom. So to summarize, I am fairly new, like they mentioned. I just graduated 2019. These are some of the tests that I don't find them being used very often out in real world practice, but I do believe as these researchers start, coming up with more and more studies that are solidifying the data, that we're going to be able to pick up these early functional changes before we're seeing the structural changes. I think these are going to become like common name within the work practice, right? With the glaucoma, with the pattern ERG, they've actually shown that the functional changes that we're picking up on the pattern electroretinogram are sometimes 4 years in advance of the functional changes we're seeing with the visual fields. A lot of the students that I kind of work with inside the clinic, they hear me all the time say, like, I'm not really a big fan of visual fields. I think it's torture, because most of the patients we're using for the visual field are these geriatric patients, right? And so they're already falling asleep, and we tell them, come back again. It's not reliable, come back again. And it's hard for them. Or I am a huge fan of objective testing over subjective testing, right? Myself, I have a hard time staying awake during any 24-2, 10-2, seat of fast or faster or fastest, whatever it is. Those are hard for me to keep up and, stay awake. So I'm a huge fan of these coming out in the future. Again, I kind of rotated with some of the retinal specialists in town, and they're actually using a lot of these electrodiagnostic testings to help them, especially with their diabetics and their AMD patients. So I'm thinking if they're already doing it, we should already jump on the bandwagon and start using these as well. The more people we get kind of using these now, in the future is going to kind of increase our diagnostic skills. I'm already almost out of time. But with glaucoma right now, we cannot charge or bill for the pattern ERG. I'm not an expert biller. I just looked it up one day because I was very, very curious, but we cannot yet bill for pattern ERG for these glaucoma suspects, right? Because there's not the recommendation from the American Academy of Ophthalmology to use those in diagnosing glaucoma yet. But this kind of reminds me, I had a professor tell me, 4 or 5 years ago, we weren't really using the ganglion cell complex to say if this is glaucoma or not. Not until there's enough research to say, okay, now we know that there's structural changes being seen in these ganglion cell hemifields, superior and inferior. They're going to correlate with these visual field dysfunctions, right? And so those all make sense. And so in my head, I'm thinking, why are these electrodiagnostic testings not being used to pick up these earlier changes and function of those retinal ganglion cells, or just throughout the whole retina in general? I think I am out of time now. These are all my references. If anybody wants, I think the handout, I think we're going to give out the handout later on in the through the emails. This is what I was reading through the comments. Let me stop this share. Do you have any questions?
Thank you, Dr. Mancha. One quick question. I know we're pretty much out of time here, but the notion that we're picking up like this pre-AMD, that you can detect a functional deficit before there is, kind of standard clinical findings. Can we reverse? Do we see improvements? Like if we were to put these patients on a special diet or have some other sort of intervention, AREDS or whatever, can we see an improvement in function after an intervention? Have you encountered any papers that would suggest that?
So I haven't actually seen any of the papers that are saying that these, one with the AREDS, we're not using them for these early AMD changes in general. That's what we've been kind of taught by literature. And especially, I haven't found anything that's going to find any supplements that we can use or medical treatments prior to the clinical manifestations of AMD. Again, because we're not really sure if that patient is going to develop it, right? If they're in that pre-AMD. Even though we know there's a genetic component, we're not 100% sold that if every person who has this genetic component is going to manifest these manifestations of AMD. But when I was doing this research, I didn't come across any kind of treatment for these early or these pre-AMD patients that would help reverse that functional loss. That would be a great study to kind of somebody to run in the future to kind of figure out, okay, how, if we know somebody's mother has AMD, their brother went blind from AMD and their sister went blind from AMD, and now this patient's in your chair and they're early, can we initiate something now to kind of reverse that functional problems that they're having? But good question. I don't have the answer, but that's a really good question.
Thank you.